I was sitting in a third-year psychology course after making an important decision. Should I attend this guest lecture or skip class and get food in the plaza? Let's just say I settled on a snack-sized bag of Miss Vicky's chips, while a brilliant young psychiatrist proceeded to tell us about her interesting career. An eager student raised their hand. "Why did you decide on psychiatry over other areas of medicine?" She told us. "Throughout my training, I was required to do rotations in every specialty. I found that I would be discussing someone's diabetes along with their depression, a broken leg along with their trauma. I chose psychiatry because mental health issues are everywhere. Mental health care is an ever-changing field in need of constant innovation and improvement. But like many areas of healthcare, mental health treatment is riddled with equity issues. My thesis is exploring this problem through the examination of gender inequity in one aspect of mental health care quality: restraint use. Gender discrepancies are not new in mental health, with variations in the presentation of symptoms, rates of mental health disorders, and even response to medications, therapies, and supports. Applying a restraint, for example, involves restricting the movement of a patient, sometimes by force. This decision involves assessing whether an individual poses a risk to themselves or others. While this may seem straightforward, there is an element of subjectivity. Right now, we are having conversations all over the world on this topic. Deciding whether someone is a risk is not straightforward, and worse yet, we are often wrong about how to manage that perceived risk. In Ontario, restraints are currently a last resort for managing aggression in psychiatric settings, as the act of being restrained can lead to a breakdown of trust between clinicians and their patients. There is a movement towards attempting to understand a patient's needs and develop strategies to create a safer environment for both staff and patients. In my research, there is a marked difference in the rates of restraints between men and women. Yet, at higher levels of aggression, this pattern flips. I want to understand what factors are associated with the decision to restrain. Because in an age with so much information to assess risk, predict behavior, and plan for change, it seems that split-second decisions based on unrelated characteristics can still be made. Mental health is personal. Mental health is complex, and it always will be. This is exactly why we need to understand how not only gender, but ethnicity, culture, sexuality, sexual identity influence the way we provide care. Only then can we move towards an equitable and responsive system where our differences are assets to recovery, not obstacles. Why does this matter? Because our physical traits are inalterable, but the way we provide care is not. Thank you.